At this time, we'll ask our first panelist to come up for the prevention case. We have Lauren Nye, of course, who is my partner from University of Kansas, who's going to serve as our moderator. Katie Nelson, genetics counselor from University of Kansas as well, and Onalisa Winblad from University of Kansas breast radiology. So if you all want to have a seat on the couch, Lauren's you're gonna sit, or there you go. And here's your slide advancer. What'd you say? What button did I press?
I think I'm going to take a seat. You ready, ladies?
Ready.
Okay. All right, we'll just jump in and get started. So our goal is to have some case-based discussions today. So we're going to start with a 42-year-old female, family history of cancer, presenting for a routine gynecology follow-up. Really limited medical history. She's had 2 children, first live birth at age 30, and her family history that's significant includes maternal aunt with thyroid cancer at age 60, father who was recently diagnosed with pancreatic cancer at age 69, maternal aunt who was diagnosed with a hormone-positive invasive ductal carcinoma at age 42, and paternal grandfather who was diagnosed with prostate cancer at age 50. So, does our patient meet criteria for genetic risk assessment? What tools do you have in clinic to help you determine that? Family history collection tools. So do you have something built into your EHR that helps you collect the family history and update it annually? Or do you have a paper form that patients fill out and gets stuck in a paper folder or scanned in where we can't find it later? But what are you using to collect family history, and are you updating it? And then are you using a genetic screening tool? So there's several different tools out there. Some can be patient completed, like the 7-question family history screening tool, where a single positive recommends a referral to a genetic counselor for further education, or a provider completed tool like the pedigree assessment tool, where a score of 8 or greater indicates a referral for genetic counseling and testing. Now, some of these were developed in the BRCA era, where that's the only thing we were looking for, so they may under-screen. But if you're doing nothing in your clinic right now to screen for genetic risk assessment, it's an easy place to start. And then welcome to the future of chatbots. This is where this area is going. So many of our industry partners here today and many other companies offer chatbots, which basically engages your patients before they show up in your clinic for that return visit through a text that takes them to a secure website that collects their family history, fills out that really bothersome, annoying form on what they need to get their genetic testing covered, and then educates the patient. Here's what your provider might talk to you about. Here's some genetic counseling education that you can understand virtually. And then when they show up to you in clinic, they're ready. They're ready to have that discussion. They're ready to do that testing. So look for different tools to help you do that genetic risk assessment. So our patient did meet criteria for genetic risk assessment. So Katie, what does that mean?
Yeah, so just based on the family history, they are meeting criteria for either insurance to cover this testing. And I do always encourage that even when we're filling out these family history forms, that when you're meeting the patient in person, just verifying that information. So the aunt of their mother was diagnosed with thyroid cancer, so just verifying your mother's sister was diagnosed with thyroid cancer, because sometimes they'll say, no, that's not my mother's sister, that's my grandmother's sister, it's my aunt. So just being able to clarify who is this relationship to this person or to your patient. And then also verifying a little bit more distant relatives, such as first cousins, great aunts, great uncles. Those individuals are still important in being able to help qualify your patient for testing, as well as can help further make management recommendations. Even though they are more distant, that family history can still come into play in some of those recommendations. Also asking about ancestry. And then this was the pedigree that was made based on that information. And so this patient wasn't as knowledgeable about their cousins or about their great aunts or great uncles, and that's gonna happen. Patients may not have as good of contact with some relatives, and may not have that information. But this patient does meet criteria based on that pancreas cancer history, that breast cancer diagnosed under 46, and in the session she had mentioned that her aunt may have had something. Can't quite remember what it is, doesn't have any documentation, which is not uncommon in our clinics, that there's just some level of unknown. So in our genetic counseling appointment, we would discuss just some differential diagnoses. What are some things that we could be telling this patient, what their results could reveal? Also going over what those possible results are, including that variant of unknown significance. Patients do have concerns about cost and insurance, so being prepared to answer some of those questions, as well as a lot of patients have concerns for their kids or their other family members. So saying that, you know, those are individuals that we are going to talk about when your results come back, about when is an appropriate time for kids to maybe consider doing this testing. And then just a plan for results disclosure. Are you going to call the patient with this information? Are you going to talk about it at your next appointment? So just making the patient prepared of how are you going to give the results to them. So after that discussion with the patient, she agrees that she wants to do the testing. A blood sample is drawn and sent off to the lab. And her results come back, and we find a PALB2 likely pathogenic mutation. So being able to know when you see this result that this does mean that it is an actionable mutation. We can make recommendations based on likely pathogenic. According to ACMG, labs need to be at least 90% confident that a genetic change that they're classifying as likely pathogenic is actually causing an increased cancer risk. And many labs have higher criteria than that as well. It's kind of a hard thing to quantify though. So certain things that you can look into are things like ClinVar. If we go to the next slide. So when looking up this specific mutation, it may be a little hard to see there, but there are multiple labs that are classifying this mutation as likely pathogenic. So we're not seeing any other labs that are classifying this as a variant of unknown significance or likely benign. As well, we are seeing a lab calling this specific mutation pathogenic. So this just gives a little bit more reassurance to the clinician, to the genetic counselor, that there's not these large discrepancies in what labs are calling this mutation. And as well, just giving you more information to share with your patient about maybe why it's being classified as likely pathogenic or pathogenic. So ClinVar is a very good resource in being able to look up what other labs are doing, as well as you can call other labs to get this information. So not all labs participate in ClinVar, and they are actually very receptive that if you call the representatives and ask, how would you classify this result? If you haven't seen it before, how would you classify it if you did see it? And they can be very receptive in answering those questions for you if you need that reassurance. So based on this likely pathogenic, we can make decisions about management, and we can also discuss cascade testing. So again, very small, I apologize. But when looking at those more detailed information in ClinVar, so when you're clicking on those arrows to look at the comments, what's really showing us, or the labs that this is pathogenic in the lab that is classifying it this way, are those internal studies. So things that are not published, that lab has internally that's allowing them to classify this as pathogenic. So looking at why certain labs are able to classify things differently may also give you that reassurance of why there could be those discrepancies. And then cascade testing, talking to the relative, or to your patient about what relatives then qualify for testing. So obviously her brother, her father, we would have a discussion of if her aunt had already had testing, she wouldn't need to have retesting, but we may need to look at that report that the patient thought she may have had something and see when her aunt had testing, was it classified as a BUS? Should she have retesting? So she can have that report that does say pathogenic. And then just going over that information for the patient's kids. When is an appropriate age to have this testing, to consider even thinking about needing this testing? Is it going to be based on when we're going to be doing screenings, or is it going to be right at 18 they want to know this information? So just going through those different options of when to consider having testing for other family members.
All right, so our patient lands back in our clinic who showed up for a well check, and now we're here with a PALB2 mutation. What do we do? The first thing is make sure your patient receives some post-test counseling. Make sure they're not freaking out on Google or Facebook and telling you everything needs to be cut off and go right now. Make sure they understand what their options are for high-risk screening and risk reduction. I love this image from the U.S. Army Corps. It really tells us about cancer risk management as well. In order to have a conversation, a communication about cancer risk management, everybody engaged has to understand what is the risk of cancer, that's our risk assessment, and what are our options for management. And then we get to input our preferences and values to determine what is the right plan for that individual with a mutation. A mutation shouldn't lead us to a checklist of you have to do X, Y, and Z. It should engage us in a conversation about what are our options to do next and what do I want to do with that information. Katie talked about Cascade Testing, and then there's also the option for pre-implantation genetic counseling for some women if they want to try and not pass down these mutations to the next generation. So Dr. Winblad, can you tell us what would you recommend for screening?
Yeah, so we know for our average risk patients, we always recommend screening mammography begin at age 40, but for our high risk patients, they actually need to begin screening earlier and they need additional screening. The screening regimen includes a combination of clinical breast exam and breast imaging exams. Beginning at age 25, we recommend our high risk patients have at least an annual clinical breast exam. Also, beginning at age 25, these patients can begin annual screening breast MRI with contrast. Once the patient turns 30, we add annual screening mammography into that screening regimen. So by the time the patient's age 30, they're typically having an annual screening mammogram, annual screening breast MRI, and annual clinical breast exam. Now, there are some patients who have contraindications to breast MRI and for one reason or another are not able to undergo a breast MRI. These patients can have, can be considered for other supplemental screening exams such as whole breast ultrasound or contrast enhanced mammography. So what are the different benefits and risks of these different breast imaging studies? When it comes to screening mammography, we recommend digital tomosynthesis for all of our patients, whether they be average or high risk. And this is more commonly known as 3D mammography. For the radiologist, a 3D mammogram helps us find more cancers. You can see the little image I have on the top right hand of the screen shows a 2D mammogram, and then on the right hand side shows that 3D digital tomosynthesis image. And you can probably pick out that that cancer that I'm showing here is much easier to see on that digital tomosynthesis image. So 3D mammograms help us find more cancers, and really importantly too, they help reduce the number of patients we have to call back for more imaging. And that's really important and impactful to our patients because sometimes recalls cause some anxiety. Breast MRI, a few times. Breast MRI, I said that we recommend breast MRI for our high-risk patients beginning at age 25. This is our most sensitive test for finding breast cancer. It has the highest cancer detection rate of all of our breast imaging screening studies. We find more than 15 cancers per 1,000 in this high-risk population, so that's why we recommend it. And it's important to note that the negative predictive value of breast MRI is really high, so we are not missing a lot of clinically significant cancers on breast MRI. So it's a fantastic study for these patients who have a high rate of interval cancers and high-grade cancers. Some of the drawbacks of breast MRI, it does require IV placement and contrast administration. It is higher cost than mammography, and there can be limited access in certain communities or certain breast imaging centers. Abbreviated protocols have been developed in the past few years. These have been really fantastic and have improved access for a lot of these patients who need breast MRI screening. So abbreviated protocols are typically shortened. They're often less than 10 minutes, and they're at a much significantly reduced price compared to traditional breast MRI. So this is a fantastic option for high-risk patients when they cannot undergo traditional MRI. If patients have a contraindication, they can undergo whole breast ultrasound. Most of our positive studies for whole breast screening ultrasound is in our dense breast population, but this can be considered in high-risk women who cannot undergo breast MRI. And this can be either handheld or automated systems as well. You may have heard of ABUS. That's a very common automated breast screening exam. breast ultrasound does find additional cancers, not quite as many as breast MRI, but it's a great study. One of the biggest drawbacks you probably know about breast ultrasound is sometimes the recall rates can be really high and the benign biopsy rates are high. So we call back too many patients, we biopsy too many benign findings. So it's really important you send your patients to a breast center that's specialized in breast ultrasound if they decide to undergo ultrasound screening, and hopefully decrease the rate of false positives. And then contrast enhanced mammography is kind of the new kid in town. It was approved by the FDA in 2011. It's really starting to gain a lot of traction in the United States, especially in the last year or two. Contrast enhanced mammography really combines, that functional imaging of breast MRI, utilizing contrast enhancement to find cancers, but it uses a mammogram instead of an MRI. So a lot of the same concepts that we use for screening, but in a different way. So it does require an IV placement. It does require contrast. It's iodine contrast for CEM rather than gadolinium contrast that we use with breast MRI. It does require an expensive software upgrade to our mammography equipment, but I think it's really important to note that it's used on standard mammography equipment. That's why it's so attractive as an option in the future and to improve access for high-risk screening or even for cancer patients, because we don't have to build a new building or a new room or buy a new big piece of equipment. It uses our standard mammography equipment. It does require upgrades, but so I see a lot of potential for this in the future, especially for programs that have limited breast MRI access. And really, it's great to see in the recent literature, we're also seeing that CEM has sensitivities approaching or comparable to breast MRI screening, which is really fantastic, and it's expected. It's a functional screening with contrast enhancement, so we expect that, but it's really great to see. And it's a fantastic alternative for patients who cannot undergo MRI. We do have patients with implanted devices or severe claustrophobia or have, cost issues, so this is a great option, and I think we're gonna see more facilities offering this exam. At KU, we're gonna be starting to offer this in May.
All right, Dr. Winblad, we have a few questions for you. Two of them are pertaining to the significance of gadolinium accumulation. One is specifically asking about it in the brain, and then just over time in our high-risk patients when we're doing this for 30 years or more, is there any detriment to that gadolinium exposure?
So there's been no proven detriment to gadolinium exposure. We do know that gadolinium can deposit in the body over time. There's been no evidence that this causes a problem for patients, but it definitely causes some patients to consider whether or not they want to do that. And I think if, there's no evidence that this is problematic, but for patients that maybe have decided they don't want to undergo breast MRI because they're worried about that or that just causes them concern, I think that would be a great patient that might decide they're really interested in CEM, as an alternative option.
And how do you, for those patients that are interested or willing to try the MRI, how do you explain the difference between the full MRI protocol and the abbreviated MRI protocol?
So really it is, a full protocol or traditional breast MRI, is somewhere around 45 minutes, and it has several sequences, and it's a test that's a little bit more specific than our abbreviated protocols. So what we've essentially done for abbreviated protocols is we've cut out several of the sequences that we have in our traditional MRI that we use in our cancer patients, and that's more specific. So we've cut it down. We're still giving contrast and, looking for those cancers that enhance, but we're just cutting out several of the sequences. And all the literature shows that abbreviated breast MRI is still finding a lot of those cancers. There are cancers that we can miss, and it's a little bit less specific of an exam. We may have to call a patient back and do an MRI biopsy or something else, but really the major difference for patients is just time. In some patients, even if they struggle with claustrophobia or just being in the MRI for a long time, may even attempt to try an abbreviated MR and be able to get through it just fine.
All right, we're going to bring it back to what do we do next? What are our options for risk reduction? In specifically the mutation carrier space, we adapt a lot of this information from high-risk carriers, individuals with just a family history that designated them as high risk. But there are some limited studies, specifically in BRCA1 and 2, but for this patient with a PALB2, we're extrapolating that information. But lifestyle, there's 3 things that have been shown to reduce a woman's risk of breast cancer. They're good for us anyway. Exercise, the goal is 3 hours a week or 180 minutes of aerobic exercise heart rate elevating, trying to hit that zone 3. If they go to Orange Theory, that's like right there. Limited alcohol, less than 3 drinks a week, max of 7, and a healthy weight, a non-obese BMI. We have options for chemo prevention, which are drugs that can help reduce the risk of breast cancer. They're not chemo, that's a big misconception, but they are anti-estrogen drugs. We haven't come a long way in this space over the decades in finding drugs with fewer side effects, so these are all anti-hormone drugs, but there is more research being done. But for now, we have our SERMs like tamoxifen and our aromatase inhibitors that can reduce the risk of breast cancer significantly. And while we don't have a lot of data in the mutation carrier space, we do still use these drugs here. And then risk-reducing mastectomy is surgical removal of the breast tissue to reduce the risk of breast cancer. And this can reduce the risk by over 90%. It also takes away the need for that high-risk screening imaging. There is no survival benefit with chemo prevention or risk-reducing mastectomy, but like we talked about earlier, for a lot of women, significantly reducing that risk of cancer and never going through all of those treatments is really important. So let's roll into our next case. This is a 33-year-old woman. She's currently 16 weeks pregnant, and she was referred to the high-risk breast clinic for evaluation. Doesn't have a significant medical history. She has 1 child already, and she's pregnant with her second. And she was referred because her sister was just diagnosed with breast cancer at age 35. She doesn't know the details. Her paternal grandmother also had a history of breast cancer at 52. So what risk models can we use in a high-risk clinic to evaluate risk? And there was a nice summary in The Lancet in 2019 that compared these risk models and their sensitivity and specificity. The breast cancer risk assessment, or the GALE model, is a quick model. It's still commonly used. It's what all of our chemo prevention studies were based on. And then there's the Mutation model, which is no longer available. The BRCA Pro, which was designed to identify individuals at risk of a BRCA1 or 2 mutation. So it does that well, but it identifies women at high risk for breast cancer in general based on family history. And so we use the IBIS or the Tyrer-Cuzick. This is the most sensitive model. You can Google IBIS Tyrer-Cuzick and it'll come up. It's free to use. And this gives us a family history-based risk. And this is what all of our screening guidelines, as well as your payers, are looking for to approve that high-risk screening. If you have a lifetime risk of over 20%, you will qualify for high-risk screening. It does overestimate risk based on breast biopsies, and that's because a lot of that information in someone with atypical hyperplasia, we know they have a range of risk, and this calculator uses the highest end of that range to estimate their risk. And so we performed the Tyrer-Cuzick, and this individual's 10-year risk of breast cancer was 2.8%, not that high, but somebody else her age at average risk would be 0.8%. And her lifetime risk of breast cancer was 27.4% compared to 11.1%. So she is over that lifetime risk of 20% threshold, where we would consider her high risk. Genetic testing was also completed. She had a panel test, and it was negative. There was no pathogenic or likely pathogenic variant or mutation identified, but we did get this polygenic risk score information that estimated her lifetime risk at 36%. And that's just an easy button. That's how you add the family history to the Tyrer-Cuzick. So it is very easy to use, and the website's down there in the bottom right. So is our patient at high risk for breast cancer? Yes. Do I need to change my management based on that polygenic risk score? And these are the referrals we're starting to see all the time now. And maybe. We don't really know yet, but we'll talk a little bit more about that. So what is the polygenic risk score? This is a score that uses single nucleotide polymorphisms, or SNPs, little pieces of the DNA, to modify an individual's risk based on their genetic makeup. So the risk score is reported as an odds ratio, and it's derived from a calculation using adjusted logistic regression. And there's just some images to see that this is still a range where we're getting these numbers from. We're getting a single odds ratio, but we know that came from a range of information. So for example, if we got an odds ratio of 1.3 is our polygenic risk score, and we're applying that to a patient with a family history-based risk of 18%. Well, now her calculated risk using that polygenic risk score information is around 22 or 23%. I don't do math on the spot well. But we've crossed that 20% threshold. She's gone from an 18% to a 22%. Does she qualify for high-risk screening? That's where that maybe comes in. Many people in the breast field would say yes. I mean, when we add her genetic information to that risk, she crosses that 20% threshold. But we acknowledge that everything is a range, and we don't know how to clinically apply these yet. So usually to my referring physicians, I say, this is really cool science. It is not quite yet clinically actionable because we don't quite know what to do with it yet, but we are ready. And in some cases, if somebody's sitting at a high enough risk, I will see if insurance will cover that high risk screening for them after a careful conversation of the risks and benefits of that screening. So the limitations of the PRS is that it's based on data, like we heard before, with limited diversity in ancestry as well as demographics. Future applications are going to include applying this to our moderate and high-risk gene mutation carriers. So taking someone with a PALB2 as a wide range of risk and narrowing where they may fall in that spectrum for them. So for this individual with her lifetime risk over 20%, youngest diagnosed relative at 35, I am going to recommend that she start high-risk screening now. And like we heard, that's going to include the clinical breast exam, breast MRI, and a 3D mammography. So our high-risk screening, whether you're a mutation carrier or you have a family history, is the same. Risk reduction recommendations, she's currently pregnant, so right now we're going to focus on lifestyle modifications, but in the future she could consider chemo prevention. So she's pregnant, so we shouldn't do anything, right? I'll just examine her.
Incorrect. So, you know, contrary to popular belief, screening mammography in general, is not contraindicated during pregnancy. I think most of us probably many years ago learned that it was, but it's absolutely not. The radiation dose to the fetus is negligible. In fact, we can have our average risk and high risk patients, continue their annual screening mammography during pregnancy at their regular interval. Pregnancy-associated breast cancer is actually fairly common. It's the most common cancer in pregnant women. So it's really important that we screen these women appropriately and don't have delays in diagnosis. We know that these women, tend to have a poor prognosis when they're diagnosed with breast cancer, partially due to delays in diagnosis. So don't hesitate to screen your high-risk patients during their pregnancy. And so this patient has her screening mammogram appropriately, and her report says that she has dense breast tissue. So what does that mean? Why is that important? This particular patient happens to be high risk, but if we didn't have a high risk patient, they were just average risk or intermediate risk, and their report says they have dense breast tissue. Why is this important? So first of all, dense breast tissue is common. It's normal. We know that nearly half of women of screening age have dense breast tissue, so you probably see this in a lot of patient reports. It's important for two reasons, though. We know that women with dense breast tissue have a higher risk of breast cancer than those with non-dense tissue. Breast cancer is also more difficult to find in women with dense breast tissue, and I've shown you a few cases at the bottom of this slide just to kind of display to you, what dense breast tissue does for the radiologist reading your mammogram. On the bottom left, example number 1, this patient does not have dense breast tissue. Their mammogram looks really gray, and I've circled the patient's breast cancer, which is really easy to see. It's a white circle on her mammogram. It's not difficult to find. But then let's look at our example 2 patient who has very dense breast tissue. So you can see all the white on her mammogram. That's normal fibroglandular tissue. That's how a radiologist identifies a patient as having dense breast tissue. There's a lot of white on the mammogram. And this particular patient, it looks normal. We don't see any white circles that look like a cancer on her mammogram. But if you look at a breast MRI this patient had a week later, and her, the left breast, her right breast, the image on the left for you, is full of cancer. All that bright colors, the reds and the yellows and the blues, that's cancer throughout this patient's entire breast. And we were not able to identify that on her mammogram simply because she had very dense breast tissue. So that's a really great case in point as to why we offer supplemental screening. Because we know the sensitivity of mammography isn't as good in patients with dense breast tissue. So, in fact, we'll move along quickly. In fact, what's interesting is most of the supplemental screening tests we offer to women with dense breast tissue are the same exams that we offer to our high-risk patients. So we always recommend 3D mammography. Screening ultrasound is probably the most widely utilized dense breast screening exam, but it's less sensitive. We find fewer cancers and more false positives. Traditional breast MRI is typically not used for this patient, but abbreviated breast MRI is beginning to be used more and more. And I think we'll also start to see contrast-enhanced mammography be utilized in this population as well as it becomes more available for our patients. And then most importantly, the types of cancers we're finding with dense breast screening are small and node negative. That's important because those are the cancers that we can treat, that we can cure. When we find those cancers that have not yet spread, we know that we're decreasing mortality and morbidity for these patients that end up having breast cancer. So supplemental screening is really important in this population. And I was just closing off with a few really great cases of contrast-enhanced and breast MRI. So if we have questions, we can flip to those. Otherwise, I can go through them for you.
We have a couple of questions,
Okay.
and I think they're good, and we have 15 seconds. So
Okay.
what I'm going to do is I'm going to have, most of them are related to imaging
Okay.
and a lot related to billing. So I'm going to have Dr. Winblad get in the Q&A and respond to your
Perfect.
questions
I
in
can do
there,
that.
okay? One was about pancreatic cancer screening in BRCA patients, and we do have a high-risk GI clinic. It's mostly research-based right now, but sometimes they are using endoscopy or MRI.
Lauren, you do actually have a few more minutes for questions if you want to take them.
Thank you. Okay, perfect. All right, so there was 2 questions related to billing. So the abbreviated MRI, is that coded and how?
So abbreviated breast MRI, typically it is, there's no CPT code yet for abbreviated breast MRI alone. So it's a limited exam. So oftentimes it'll have a limited, breast MRI limited charge. And typically facilities have a particular charge that they offer for that breast MRI exam. At KU, it's a $500 test, but that does go through the patient's insurance. We're finding that it's often covered. But there's not a guarantee, so we let patients know there could be, cost sharing or full cost associated with that exam.
And will the contrast-enhanced mammography be covered by insurance?
So most of the time, contrast-enhanced mammography is like a diagnostic mammogram charge and a contrast charge. Different facilities are going to charge that differently, and all likelihood, it's probably going to be something, cheaper than abbreviated breast MRI. But it's going to be different. Typically, it's a diagnostic mammogram charge.
And then do we use MRI in pregnant or lactating women? And how do lactation changes decrease the sensitivity?
So typically, we are not performing breast MRI in pregnant patients. For lactating patients, that's fine. There's no contraindication to performing screening breast MRI in lactating patients. Sometimes these patients can have a lot of background enhancement just because of, they're lactating, there's a lot going on in the breast tissue at that time. And, traditionally, I think we've always thought that can decrease sensitivity, but there are actually a lot of studies showing that we're not missing breast cancers in these patients. At KU, we're lucky to have some excellent, software that allows us to do very early post-contrast evaluation of breast cancers and look at tissue before it's actually gotten to that background parenchymal enhancement stage where everything's lighting up, and so we can really still find cancers in these high-risk patients who continue to lactate. I wouldn't delay their breast cancer screening because they're lactating. The imaging still does a really fantastic job in these women.
Perfect. Yes, one question from the audience.
Yeah, I have a couple of different questions. Sorry, this is Jennifer Rogge. I'm a nurse practitioner at KU. So when you say annual MRI and annual mammography, is there still that thought that you do them annually but 6 months difference because you know that you can have some changes within a short period of time? And then what is the incidence that you can actually detect more lobular breast cancers as opposed to invasive ductal?
So we have patients do both. regimens. We have some patients who like to get their screening mammogram and ultrasound or screening mammogram MRI at the same time once a year, and we have lots of patients who do every 6 months. You know, theoretically, the nice thing about every 6 months is there's always the ability to catch those interval cancers. We know that high-risk women tend to have more interval cancers than our average risk patients do. So when you screen every 6 months, you're hoping to catch those interval cancers, especially when they're high grade and they didn't show up 6 months prior. So there's always, you know, a little bit of benefit to that. But, you know, the reality is if what's most important to me is that they have their high-risk screening. And if for some patients, if they just would like to only come 1 year, that's a very great option too. And then your second question was related to invasive lobular and ductal. Was it about a particular type of imaging?
Well, so my patient was a genetic mutation carrier and was doing the screening annually, and within 2 months had a palpable mass, and it was found to be lobular. They did imaging, they did MRI, we did neoadjuvant chemotherapy. At the time of her double mastectomy, they found cancer in the other breast, which was also lobular, that was never detected. So my question is, don't we typically see lobular cancers not detected as well? And is the contrast enhanced mammography maybe going to help pick that up?
Yeah, so I think contrast enhanced mammography will be similar to breast MRI, essentially. Invasive lobular cancers, we most of the time are able to pick them up with breast MRI and screening exams, but invasive lobular classically tends to be the type of cancer that can be more tricky to find. And we do see those cases where we can't identify it in imaging. And even sometimes with breast MRI, or what we're gonna see with contrast enhanced mammography, is a lot of times they have really delayed contrast enhancement. So, you know, you really have to be looking at those delays. In fact, that's the concern sometimes with abbreviated protocols, because you're just doing, you know, shortened exam, one follow-up, that there's always the potential to miss an invasive lobular cancer if it has not yet had time to enhance. And the reality is, too, for those patients, mammography continues to be very important. Clinical breast exam continues to be very important. Lobulars can be really tricky cancers to find.
All right. Thank you very much.